Everybody can see the slides, can they?
Yeah.
Okay.
Yeah, we can see them.
Yes.
My camera is in the center here, so I have to look from side to side to accomplish this task. I just want to say that, and I've got two screens, so I'm not doing my grocery list or anything else. I'm just trying to orient myself on the correct screen, so that's why I'm looking back and forth. But it was nice to be invited to speak, and we haven't done really any presentations since COVID began. So this is, I suppose, a test of whether it works or not, to be able to do this via Zoom. As I say, it was very nice to be asked to present. So we're grateful for that. I have invited along Laura, who's maybe could wave so we know which one you are. Who is one of our assistant psychologists. I mean, I will introduce everybody a bit more later on. And Emily is here, who is another, well, this is the last day of her very first month with us. So we thought it would be a good sort of induction activity for her to join in. And my name is Vicki Bliss. I'm a clinical psychologist. I think we can go to the next slide, Mabel. Do you want me to do that? Oh, I can't do that on your thing, can I? Next slide. Yeah, I'm busy.
I can see the second slide, can't you?
No.
Oh, I did it, and it says Lancashire Autism Service began in 2004.
Oh,
That's
no.
what I have on my screen.
No, that's not on my screen. On the share thing.
How can that happen?
I don't know, perhaps, is it frozen for us? It's also, I have a picture of your actual screen. So all of the words, you know, it's not on the screen show, the slideshow.
Oh, it is on the slideshow here.
It's not filling the screen like it
Well,
usually
let
does
me
when you start slideshow.
Oh,
there we go. Wow.
Yeah.
We went to the second.
Can you see it now?
Well, now it's gone again. Now I'm back on page 1, slide 1.
Well, I'm on. Okay. Can you see the second one there?
Yes, there it is.
Right. So if I put it in presentation, it doesn't do it.
Oh.
For some reason.
Okay.
Okay. So we can
carry on this way.
Does it work like that? I can make it bigger.
That's good.
Oh,
yeah,
that's too big,
good.
I think.
That's good for me anyway. I guess it's okay for the rest.
Is it? Can you read the whole thing like that?
Yeah, if it helps, I can read that.
Or there. Which
read it? The previous one was better. Bigger.
Okay. Okay.
There. That's good.
Okay. So it looks as if we have to work with this because it's not working the other way.
Okay. So the pressure is on now to make sure the slides are interesting enough to have warranted the messing about with them. And I'm not sure that's true.
Oh, come on. Yes.
So I kind of started as a sole trader in 2004 when I left the NHS, and the NHS were increasingly asking me to do individual diagnosis, just paying by individuals until about 2013 when we got a contract with the NHS just in Lancashire. So the contract, the terms and amount of funding and everything has remained the same since 2013. So they've not upped the pay or anything since then, which is kind of naughty of them. We'll go through the process, the diagnostic process. It's essentially the same if someone is coming privately. The process is the same, although obviously the funding is different. When I set up the business, I was keen to employ people who had autism in any capacity that would work. I assumed it would work in every capacity. And we've had various iterations of that over the years. It turns out that neurotypical people have a part to play as well. I didn't have much use for them before, but as I started to get into business, it seemed like we needed to kind of have the benefit of both, really. So most of the people employed, we're a very small service, most of the people employed have some kind of personal connection with autism. So it still is pretty much run by people who understand the condition very well. I think I could say it that way. We do two different kinds of work. So we have a diagnostic pathway that we'll talk about, and we provide a strengths-based, solution-focused based therapy for people and those who care for them. And we work mainly one-to-one, except of course the diagnosis involves family and friends, but we were starting to do some very well-received groups before COVID came along. But it has proved challenging in a way like this to set those up online, the group-based activity. So we are still working on that. If we could, yay. Our staff, MD Scott Lord, who is a person with autism and ADHD. There's all of my names, various names. I'm undiagnosed, but very certain that I have autism. Sarah Tovey is a specialist counselor. She, apart from myself, is the longest serving person. Laura Price, who's with us today, is assistant psychologist and takes the lead on managing a lot of the client data. Smia Dasu, who's recently had a baby girl. She and Anisha Khan. Well, Samia's been with us about 5 years, I think, and Anisha, maybe she started the day that the lockdown began. So poor woman didn't get to work in an office with us. She's had to learn everything via the online work. And then Emily has just joined us. And I will say more about everybody a little bit later on. And we've offered the post of receptionist to somebody. We hope they can start next week. We're not there are a couple of hiccups with that, so we really need that person because we've been trying to manage that, or say I don't do very much of it, but Laura and Sam and Anisha and Sarah have been trying to answer phone messages and answer emails and to get back to everybody in a timely way whilst managing a clinical caseload, and it has just proven impossible. As an example of the sort of increase that has happened since we've been working online, there were 38 emails in the space of an hour yesterday when I was talking to Sarah. So it's just ridiculous, and we do need, it's a full-time job now to keep on top of that. So, oh, there's my background. Yeah, I don't know, that will be there. I guess the slides will be published after. But I have a history of growing up in Iowa. But I've now lived in this country longer than I lived in Iowa. So I was hired to come across and teach at a university because I was one of the program directors of an internationally recognized service in Nebraska, which was a community-based service for people with learning disabilities in America, well, in the Midwest anyway. The process of moving people out of institutions began before it did here. And I was hired because I had some experience in running a community service. But oddly enough, I wasn't hired to do that. I was hired to run a post-qualifying behavioral approaches course for people who challenged the services, because unsurprisingly, I guess, it was a lot of the people who had challenging behavior were the last to leave big institutions and move into the community. So the course was designed to teach social workers and nurses and education staff how to work with people who were challenging. So I came across in 1990. I set that up and ran it for 6 years, turned it into a diploma course, and then handed it over to carry on, which it did for several years thereafter. But I returned to clinical work in 1996 and did that between two different services until 2004, when as I said earlier, I started the private work. I've also worked in health psychology in the NHS in Southport, which was interesting. And oddly enough, a lot of people with neurodiversity seemed to find me there. They were referred for health-related reasons, but they were generally the people who maybe didn't think or process information in the same way that other people do. And I worked for 7 years in children and young people clinical psychology service in East Lancs. So that was invaluable in terms of child and family experience and understanding more about education services and what is available to families when their child has a difficulty is very different than what's available to adults when they have a family member with difficulty. So I mentioned Sarah, who's ill today, unfortunately. I had just moved into the first office when Sarah poked her head in and asked if we were hiring, because she'd heard that I needed a secretary. So I pretty much hired her on the spot because I just needed somebody right then. The phone was ringing, I guess. She had experience at the Samaritans working on the phone lines, and their training is second to none. So it was clear that she could handle any kind of risk that would come up in our line of work. So, excuse me, well, she's been with us, she's done her counseling degree and now pretty much runs things on a day-to-day basis while carrying the clinical caseload. She supervises the staff and even liaising with commissioners, although Laura, I know you do some of that as well. She and Laura really, as the senior staffer, that wouldn't be able to do it without Laura, who's with us. I can't remember, Laura, how long ago you were hired. You said several years, but I know that we hired Laura to do the admin and natural and had a way of interacting with people with autism, which moved quickly into a clinical role. Bachelor of Arts in Psychology, I think you have. And now you're going to be starting.
Vicky, is you recording from your end?
I don't think so. I don't know though. I push record now and it's gone through.
Okay.
Now recording. I don't know, is there anything I can do about the sound, Mabel?
Yeah.
Okay, so it's just
sorry
me.
about
That's
that.
fine.
I was just heaping praise upon Laura. And as I said, Sarah and Laura will join them, do the majority of that service.
At all.
Oh,
So
no.
you'll have the slide. I can't understand what you're saying.
One. Next one. Next one. And the next one. Okay, well, we skipped over Emily Norman there. Again, Emily's with us today as part of the induction, but comes with a background of health psychology, which we plan to use to offer group sessions. That's it. Fitting really well into our team, and we're just delighted to have her join us. We've offered the post to receptionist. We've just been overrun with people trying to contact us, and we cannot get back to them quickly enough. So I was asking of autism, and I guess you're probably familiar with the Diagnostic and Statistic Manual, 5th edition, the DSM-5 of 13 moved the triad of impairments into a dyad of impairments. So it's moved from 3 general areas of communication and interaction, as well as or sensory sensitivities. So it makes sense to put those things together. Previous to that, well, there's also the ICD-10, at least very much that America would refer to the ICD-10 at all, where at the moment still being diagnosed by the triad of impairments. And the options are childhood autism if the issues were before 3 years of age. Atypical autism if the person was that they don't quite meet all the criteria, and then a separate diagnosis for Asperger's syndrome, and no delay in cognitive development. There were all sorts of problems. Well, there still are all sorts of problems defining what autism is, because people who have the condition are affected by it in so many different ways. So the idea that there would be evidence of autism before the age of 3 is okay if you're diagnosing children who have parents that knew them before the age of 3. But we're in the business of diagnosing adults, and sometimes, probably 30 to 40% of the time, they don't have anybody still alive or still within their network that knew them when they were that young. And we don't have people, or they don't have people that maybe have a good memory for things, or parents were occupied elsewhere. I mean, and the parents are 70. There's been a lot of sleeping since that child was 3 years old. So a lot can be forgotten. There's just all sorts of difficulties with the historical gathering of information. Asp used to mean somebody who was bright, but also had autism. And that was not the diagnostic criteria. So technically, to have a diagnosis of Asperger's syndrome, a person had to be speaking before the age of 2 years old, for example. And again, a lot of times we didn't know if that was the case or not. We didn't know if there was a diagnosed cognitive disability. It was the fact that it came to mean so many different things in a field that was already confusing, that the diagnostic, the DSM-5 in America did away with it. The ICD-10 has updated now, and they theoretically in January 2022, they will also be diagnosing based on the DIAD, this similar to the DSM-5. So, and I do think that's a step in the right direction, although the diagnosis is still fraught with a lot of difficulty in terms of gathering the information. So for the diagnosis, there's, I guess, everybody who does diagnosis, we follow our interview format that was developed from the Autism Diagnostic Interview Revised and the AAA from Simon Baron-Cohen. You can find these things on the internet pretty readily. You can find out about them. You can't actually get the assessments themselves, I don't think. So we kind of, those are two things are still structured in the three impairment format. They haven't updated, unfortunately, and I don't know if there's a plan for them to. So we sort of developed our own based on that. There's also self-report. So it's absolutely essential that we see the person that we're assessing so that we can do some informal observations. So we can ask questions so the person gets to speak for themselves. Even if they don't say very much, it is very, very important that we see them for, you know, an hour, 2 hours, if at all possible. I mean, it's going to be very difficult to diagnose without seeing them. And that was a worry when COVID hit and we couldn't do home visits and people couldn't come to the office. However, we've used virtual means, and it has worked out because 95 to 97% of the people are happy to do it that way. And actually, it means they don't have to come to an office. They don't have to get public transport. They are in their own place of comfort. So it's kind of worked out better for a lot of people. But there still are some for whom it's a significant struggle. There's also self-report via questionnaires, the empathy questionnaire, the autism questionnaire, and the AQ10, which is part of the referral process. Those are all questionnaires the person answers on a 4-item scale. I think they're 4 items. So we require those before proceeding with the last diagnostic assessment. They are not diagnostic in themselves, the questionnaires, but they do provide a good adjunct to information from interview and from observations. It's really, really very important. I can't stress how important it is to talk to somebody besides the person who's being assessed. Ideally, someone who knew them when they were growing up. If that's not available, then a friend or an employer or a coworker, someone who's known them for a couple of years would be very important. And the reason that that's so important is because some people with autism do not have a lot of insight into how they affect other people. So they may say, for example, I don't interrupt other people. And we may notice that they've interrupted us, which is frequently the case, but they might be able to hide that for a short period of time. So we do need somebody else's insight into how they come across and what struggles they seem to have. It's a much more robust diagnosis if we have somebody. Previous reports, school reports, very helpful, medical information, mental health information, we read it all. So that's important as well. And then observations. Sometimes when there's a question over whether somebody has autism, we might do something called an ADOS, which was really developed for children, but there is an adult component to it. It's kind of embarrassing to do because you're asking an adult to make up stories and, you know, play with a lollipop stick as though it were a person, and it is kind of embarrassing. At the same time, it allows us to set up situations involving imagination, involving sequencing of activities, involving intuiting the emotions of other people to get a firsthand look at how they come across to other people. So I have done it. A couple of people were just too insulted to even participate, and some people quite enjoyed it. So we can do it. For kids, it can be fun. But for adults, it has its points. Next one. There are some very exciting and interesting things in the field of neurology, brain differences, chemical differences, wiring differences, and in the field of genetics that I think will become, if not the best way to diagnose autism. Sugar's over this, it's diabetes. If it's under this, it's not. There just isn't anything like that. I've lost the screen. I don't know if anyone else has the screen share, but I can keep talking. So there isn't anything like that kind of a marker for autism as yet. I was reading, thank you for the link, Mabel. I was reading about some genetic tests that are offered in America if you're lucky enough to be in certain areas and have the right insurance. We do offer the same things here. They are generally for syndromes that are known for other reasons, though. The link to autism has been accidental rather than a reason to go get the genetic testing. So Williams syndrome, for example, there are physiological issues with people who have Williams syndrome that caused them to have genetic testing. And as it happened, they had also some markers for autism. So we aren't anywhere near the place yet where we could say, go see your neurologist for a diagnosis. But I think we will get there. I think the bigger the databases get and the more we can participate in funded research, the much better likelihood there is. So I think that was one of the questions from somebody is made me laugh. Why are psychologists involved in diagnosing it? And if that's indicative of some reservations about psychologists as a breed, I share that reservation. But neurology is just not set up for it. Genetics are not yet set up for it, although genetics are closer than neurology are to being set up for it. And the cost of the assessments are prohibitively expensive for the gain that you get. So you would most likely get information about other genetic issues rather than autism, is my experience. Next slide. Next one. Our diagnostic process. Waiting for the slide.
I know, I'm clicking and
Well, this is my area of intense interest, so I'll just keep talking. A referral from, at the moment, it's yay, from the GP usually, or from a community mental health team. For the NHS ones, for private one, families can self-refer, or the individual obviously can self-refer. When the GP makes a request to the NHS, a place called the Commissioning Support Unit, agrees the funding, and then lets us know. When that's done, we pretty much immediately, I think, send out a welcome pack that says, here's some information we need from you. And when they get back to us, that's when our clock starts ticking. And from that point on, they become under our service. So we assume responsibility for them. I'll talk a little bit about what that means. From the moment we get the person's information back, we might need to write letters for them so they can get reasonable adjustments whilst they're undergoing the process of the assessment. That might be to employers, it might be to university, it could be to family members, I suppose. We could, if we know enough about them, we can write maybe in support of benefit application. We can do some one-to-one sessions with them, or we can do some support for family during those times as well. That's time limited, because if there's in-depth work that's needed, that's a separate piece of work that goes into the counseling section of the service, and that would require additional funding. So when we get the information, they go on our system, and basically they get scheduled for the first appointment, which happens maybe within 4 weeks now, would you say, Laura?
Yeah, quite easily within 4 weeks.
Yeah, yeah.
Receive their information, yeah.
So when we hear of places that, you know, you have to wait years between referral and a contact, we feel a bit smug, because it isn't anything like that with us. It can be a year or even longer before we finish, but to get you some support and to get you into a service where advocacy going on, it's a month, which is pretty good going, given that we cover such a massive area of the northwest of England. There's a first appointment, which is meant to be brief. It's meant to be 20 minutes. Sometimes it's 2 hours, but it's meant to be brief, where we check in with, just to make sure that we're on the same page as the person. They're referred for an assessment. They know it's a diagnostic assessment. They know what kind of information we need. We find out who else is involved. We do a risk assessment. And obviously, if there's any indication of risk of danger to self or others, we refer on as appropriate. We might get back to the GP if there's a need to do that. We might ask the GP to refer on to ADHD services or mental health services, or to a chemist so we can get some medication information. We might do any one of a number of things to start putting together a profile of this person. Then how long, Laura, do you think it is before the second appointment?
At the moment, I think it's about six to 8 months.
Yeah, now there's
that first one.
Yeah, the detailed interview is the main body of the assessment, and there's a lot of note taking and a lot of kind of putting information together that makes that a more in-depth and time-consuming process for it. So we don't get to that as quickly as we do to the first appointment. So that people will have, all being well, filled out the questionnaires by then. They will have sent us any additional information. We will hopefully have talked to other services involved if that's necessary. And then we collect information from before they were born, if we can, to the present day in terms of social development, meeting developmental milestones, education, primary school, secondary school, college, university, any additions to university, all the employment that they've been through, friendships, current relationships, medications, other diagnoses, always assessing for risk in there. And then finally, we get around to asking specific questions that are directly related to the diagnostic criteria. The final decision, we get the detailed interview, the second one back, and then that gets presented to the team. We make a team decision about diagnosing autism, and I didn't mention it earlier, but the DSM-5 criteria gives 3 different levels of autism. So level 1 is a person who can put on a social coat, if you will, and kind of pretend to make eye contact and hello, how are you, and do those social exchanges briefly without anybody noticing that there's anything different. It's exhausting for people to do it, but they can do it. Level 2 is someone who really can't do that, and they're likely not to be able to speak or to stare at a person or to not give any eye contact, or there's going to be something noticeable about their interaction, even to somebody who doesn't know them very well. And level 3 is someone who generally will have intellectual disabilities or developmental disabilities and need more like 24-hour care, so that the autism is very, very obvious. And probably combined with learning disability. So we will discuss what we think the level might be, and then someone from the team will bring them back. That's one outcome, where we say this is what the team decided, and we'll discuss with them what they think the level is. Sometimes it matches with what we think, and sometimes it doesn't. I generally go with what people think. The other option is that I could see them if it's kind of tricky in some way. So we have had one recently, and it brought to mind another one that was a little while ago, where in one instance, the person, and Emily and Laura, we were just discussing this not so long ago, the one person ticked every single box, and they ticked it, definitely agree, definitely disagree. There was no middle of the road. And it just felt like it was too clear cut. And we weren't really sure if that was someone who really wanted to have autism and maybe didn't, or if it was someone who had autism and was just completely black and white and didn't really have any insight into why there might be a maybe sort of answer. So that might be someone that I would see, and I would rely a lot on observation then, I think, plus maybe hearing what they don't say. And I'm not any better than the other clinicians in the service. I just am older, so I have more experience. I think that's all it is. The other one is where they don't tick anything, and we think you are so autistic within maybe 15 seconds of seeing them. That's an exaggeration, but we think you really are autistic, and they just have no insight maybe into how they present. So they're saying, yeah, I had friends. I started walking and talking at the usual times. Yeah, I've had lots of friends. I still know the name of a friend from primary school, so I have experience in keeping relationships going. You think that's not really what we mean by keeping relationships going. So those are two kind of, one meets all the criteria in a kind of very tidy and unusually clear way, and the other one didn't meet very much of the criteria, yet we think, well, something else is going on there. I've completely forgotten why I started talking about that now, but it was, I guess, because that might be, those might be some of the people that I would see rather than make a team decision. So I guess I would see and perhaps go back to the team to say, no, yikes, I didn't get very far, or yeah, I did, and I think it's probably this. There are also people who have significant mental ill health, and it seems like the referral for those kind of people are increasing.
Yeah.
Complex people. It's very difficult to do, but these are people who I'm not sure some of the time. And so again, it isn't that I'm better or brighter than any other member of the team. It's just that I've been around longer and I've seen it because I've worked in hospitals and I worked in communities, and I've seen perhaps more examples of various things. So sometimes I might see those people as well. Anything to add to that, Laura? Do you think about our diagnostic process and decision?
No, not really. I think you've covered all bases there.
Yeah, thank you. Yeah, but it's There were some questions the group asked about people maybe qualifying for diagnoses happen. I think a difficult, sorry, Mabel, we will get there. In situations like that, we get a feel for the person. I can't put it any other way, but you kind of feel like they have autism, or you hear what they're not saying, and you can work out from experience how they would deal with situations. So we can maybe set up some situations to see how they respond to them, a bit like the ADOS observation. So we try to, the final decision then is a short letter that just pretty much says the person's attended and they have ASD 1 or 2 or 3, 1 or 2 usually in our service. That goes to the GP and to the person, with a copy to the person, and then they get a sort of longer letter that explains, excuse me, explains better how we came to that decision. We try to do that in a timely way, though that hasn't always been the case, which has been largely my downfall.
But they are a very nice personal document as well. They're nice for people to have to understand themselves better. I find a lot of people are always really happy with the reports, and it helps kind of them make sense of a lot of things when they have it there in front of them, black and white.
Yes, that's been my experience as well. And I think one of the things that might make it more useful is that we highlight the strengths of the person as well. So there's a lot going for a person with autism. It may be that there haven't been in a lot of situations where people have really listened to them, but there's a lot of humor and a lot of skill and a lot of genuine, heartfelt kindness toward other people. There's lots of things that we put into the report as often as we can, because it's not, in my mind, and I think in the rest of the team's mind, it isn't an awful thing to be diagnosed with.
Yeah.
It's kind of an explanation of how your brain works, but it isn't something wrong with you. So that sometimes helps. One of the questions was, people not accepting the diagnosis. That sometimes helps, because it is not something wrong with you. It's an explanation, like explaining why you're left-handed. It's explaining why and how you miss some of the social contacts. Your brain was developed beautifully to pick up on details and to be systematic and to be logical. And then your brain goes out into this chaotic, noisy, smelly, busy world and panics. And it panics because of the connections that it's making. It thinks everybody should be logical, and people are not logical. They're crazy. They're absolutely nuts. And those people are driving buses. And so your brain panics and thinks, God, we're all going to die, because people are not logical. So it's not something wrong with you. It's a difference that has made some things harder than others for you. Oh, you can tell it's my specialist subject, okay? So this diagnostic, oh, you've moved on. That's a good thing. Counseling service. The counseling service then, private or NHS, the NHS generally fund in blocks of 5 sessions, which is an odd number, I think. Well, it is an odd number, but it's an unusual number, because sometimes it takes that long to establish a relationship with somebody, especially if they didn't really want to come. 10 sessions, 12 sessions. I like that one, because oftentimes we meet once a month, or 20 sessions we've had approved, but I'd be happy with any number of sessions, so long as it gives me time to do what needs to be done. Social services have had their arms twisted a few times to provide funding on rare occasions, and then of course there's private funding. We do not at the moment work for insurances in the UK. Well, we don't in America certainly, but we don't in the UK either. Like, what's a Bupa, for example? We're not registered with Bupa to provide. They're pretty much the same reasons anybody gets referred to a psychologist or to a counselor. All sorts of things, really. Something's not going right. And the main thing is that the person wants something to be different. And that thing that they want to be different has to be within our remit. So people have come to me before because they wanted to move out of their current house into a better house, but I couldn't help them do that. So that was not the right service. And they were genuinely startled by that. But I was really glad we had that discussion, because I would have tried to make sales. So, okay. And that, so yeah, and it has to be something that we can achieve if we work well together. So another person came and he wanted to be able to, he didn't want to get caught at it. So he essentially wanted to be a better thief. which we probably could accomplish if we worked together, but that wasn't something that we should do. So we didn't do that either. We have to be able to have those discussions. Next one is based based in applied behavioral analysis. I know lots and lots about both of those approaches, as well as dialectical behavior therapy, which is what people with personality disorders, all of those other options, I liked in the driving seat. For me, it works best because my image is I'm sitting next to the client and we're both trying to get to their goal. Whereas in CBT, for example, cognitive behavior therapy, it was kind of like I was sitting opposite the client. They were saying they wanted to be happier. And I was saying, well, if you want to be happier, you're going to have to do this, this, and this. Whereas now I can sit alongside the person and say, how are we going to get to being happier? What's the steps going to be? How can we support you to get there? I'm not telling them what they have to change because they probably don't. I don't know what they have to change. And I quite like that as well. I don't have to know so much to be a solution-focused therapist. And it puts us in a kind of co-working, having discussions together that some people can have in their own head and get to where they want to be, but some people need to have those conversations outside their own head with someone who can give them some ideas. So it's based on the person's already doing a lot that works. It just gets forgotten because what doesn't work is so big or so dangerous or so upsetting. And that becomes the focus. So we forget the things that we do well. We want to do some more of that, which sounds really simple, but it isn't. And make small changes that lead to big changes. And as I said, sitting alongside the person. Now, we can, at mindfulness, we do some of that. And now that Emily's here, we've added meditation to that bag of tricks, which I think will be fabulous. We can do some aspects of DBT and CBT, but it will be within the context of explaining it to the person, us deciding together that borrowing a bit from that will help us get to where we want to be. So it's not prescribed. It's not a set way of doing things as such. Exposure for phobias, we have people who we just kind of gradually get used to pictures of spiders and then real spiders, that sort of thing. A lot of giving information. And so we just call that teaching. So here's what's going through the mind of a person without autism, and teaching people like that to kind of give them a leg up in trying to understand those crazy, insane people who do not have autism. Generally, it's one-to-one. I've done some couple work. Sarah's done some couple work. We were doing groups. Love to include families if that's where what the person wants to do. Next one. I'm enjoying the dog, by the way. Enjoying the dog in America who's walking before in front of the camera. Thanks for bringing them. I've kind of said all this. We're always mindful of safeguarding. We have to do all of that rigorous training, and we will make referrals to the safeguarding people. Making referrals onwards can sometimes be a risk itself, I think. I get quite possessive, I guess. I get quite protective is the word, of the people that we see. And I really want to know what's going to happen if I refer them into a mental health team or refer them into a crisis team. And I tend to try to tell those teams how to do their job, and it doesn't make me very popular, and it probably isn't necessary. But if people with autism are getting used to having autism, then they get referred into a team that doesn't recognize that and is just, they say they understand autism, but they get mad at the person because they're too blunt, or they say they can't work with them because they don't give any eye contact. They think they're lying. It's just a nightmare. And that continues to be a worry for me, although training for mainstream services is much improved since 2013. So it's less of a problem. It's just always in the back of my mind, do we really need to refer this person? And the answer should be yes, probably. Same rules of confidentiality as what you're probably familiar with. We would not share any information with anybody without the person's permission unless there was risk involved. So people can say it back to us pretty much. The treatment plans, we're working on formats to write those down. It is kind of difficult because you don't know what the goal is until the person tells you. Whereas in other therapies, you can say the goal is to reduce anxiety. In solution focused work, as I said earlier, that might not be what they want. They might want to, learn more about COVID. I don't know. So I have to wait till I see them before being able to write down a plan. So the therapist's job really keep the sessions future focused as possible, whilst being useful, I guess. And that's something we try to assess all of the time. Is this working or is it not working? Phew. So that's been an hour. I'd just like to say anything else, please.